4 inches from the patient's nose. Then ask him to look at your finger, at the wall behind you, and back at your finger. His pupils should constrict when they focus on your finger. Next, perform the cover-uncover test. While the patient stares at the wall behind you, have him cover one eye with a card. Then observe his uncovered eye. It should not wander or move. When he removes the card, watch the eye he's just uncovered. It should not wander or move. Inspect the patient's cornea and lens for opacities. Then test his corneal light reflex. To do this, instruct him to stare straight ahead while you shine a light on the bridge of his nose from 12 inches away. If both corneas reflect the light in the same spot, the eyes are properly aligned. Next, inspect the pupils. Normally, they're 3 to 5 millimeters wide and equally round. Also, check the patient's pupillary light reflex, which assesses the optic and oculomotor nerves. To do this, darken the room and shine your light on one pupil from the side. Normally, this causes both pupils to constrict or become smaller. For example, when the light shines on the right pupil, that pupil should constrict directly, while the left pupil constricts simultaneously and consensually. Document this finding as PERLA, which means pupils equal, round, reactive to light and accommodation. Now you assess the internal eye structures. First, prepare the ophthalmoscope by selecting the lens size, turning on the ophthalmoscope, and adjusting the aperture to find the largest beam of light. To examine the patient's left eye, use your left eye and hold the ophthalmoscope in your left hand with your index finger on the lens selector. Instruct the patient to look at a fixed point straight ahead and to keep his eyes still. Approach him from about 15 inches away and at an oblique angle. Then focus a small circle of light on his pupil. You should see the red reflex, a reddish glow that fills the pupil. Keep looking at the red reflex as you move toward the patient. As the retinal details become sharper, follow the blood vessels until they converge at the optic disc on the nasal side of the retina. The disc should be a yellowish-orange to creamy pink oval or round structure. Use 1 disc diameter, 1 dd, as the basis for measuring any retinal background lesions, and use a clock face to indicate the lesion's locations. Also observe the physiologic cup, which should be about half the size of the disc, the retinal vessels, which should appear as a pair, a vein plus a lighter, thinner arteriole, the fundus, which should appear light red to brown red and free of lesions, and the macula, which should be about 1 disc diameter, temporal to the optic disc, and should contain no blood vessels. Remember, always inspect the macula last, because shining your light on it may cause tearing and pupillary constriction, which could make it difficult to continue the exam. Now assess the patient's ears. Ears can vary greatly in size and shape, but should always line up with the eyes. Inspect and palpate the ears. They should be symmetrical with no swelling, lesions, thickening, or pain. Now palpate the mastoid process behind the ear. This should not cause tenderness. Next, prepare to perform the otoscopic exam. To examine the patient's ear, hold the otoscope in your dominant hand. Between your thumb and fingers, pull the pinna of the ear up and back to straighten the ear canal. Remember, you'll need to look in all directions to view the entire tympanic membrane or eardrum. Now inspect the external ear canal. You should not see redness, lesions, swelling, or exudate. Now examine the tympanic membrane or eardrum. It should reflect the otoscope's light and should appear shiny and gray with a white periphery. Its center should be concave with no perforations. Note the malleus and the light reflex. Occasionally, you may see the incus. Finally, withdraw the speculum. If you see exudate on it, change the tip to prevent cross-contamination. Next, you'll assess the patient's hearing by performing the voice, Weber, and Rinna tests. For the voice test, gently occlude one of the patient's ears with your finger. Then test the other ear as you stand 1 to 2 feet away from him. Ask him to close his eyes. Gently wiggle your fingers in his ear while you whisper a 2-syllable word. He should be able to repeat the word you whispered. Next, perform the Weber test to assess sound transmission through the skull bones. For this test, use a tuning fork of 512 to 1024 hertz. Hold the tuning fork by the stem and then strike the tines on your palm. Place the stem of the vibrating fork midline on the patient's skull. He should hear the sound equally in both ears, meaning his conductive hearing is normal. Next, perform the Rinna test, which can detect if the patient has conductive hearing loss. Strike the tuning fork again and place its stem on the mastoid process. Count the seconds until the patient says he can no longer hear the sound. This indicates bone conduction, or BC. Okay. Then immediately place the still vibrating fork close to the patient's auricle near the ear canal. Count the seconds again until the patient says he can no longer hear the sound. This indicates air conduction, or AC. Normally, air conduction is about twice as long as bone conduction. To begin this part of the assessment, briefly inspect and palpate the external part of the patient's nose. It should be fairly symmetrical, with no lesions, deformities, or deviations. Now have the patient occlude one nostril as he inhales and exhales. Air should flow freely in and out of the other nostril. Good. If the patient reported an impaired sense of smell during the health history, test the olfactory nerve by having him identify specific smells with his eyes closed. As he occludes one nostril at a time, pass an aromatic substance like vanilla, cloves, or coffee under the unoccluded nostril.
Coffee.
Next, inspect the nasal cavity using an otoscope with a short, wide-tipped speculum. To widen the nostrils, apply gentle pressure on the tip of the patient's nose with your thumb. Then tilt his head back slightly and insert the speculum gently into each nostril. Avoid contact with the sensitive nasal septum. Hold the otoscope handle to one side to avoid the patient's chin and to improve your mobility. Direct the speculum toward the back of the nostril, then move it upward in small increments to view the nasal cavity. You should see coarse hairs lining the anterior surface and a ciliated membrane lining the posterior surface. Throughout the nasal cavity, the mucosa should appear pink and moist, and you should not see lesions, drainage, or obstructions. Now inspect the nasal septum and note any deviations, inflammation, or perforation. Remember, though, that a deviated septum is normal unless it obstructs airflow. Finally, inspect the turbinates, which are located laterally. They should be light red without any swelling, exudate, tenderness, or polyps. Now ask the patient to bite down and bare his teeth while you assess jaw alignment. In the front of the mouth, his upper teeth should override the lower teeth slightly. Before examining the mouth, ask the patient to remove dentures if he's wearing them. Inspect the patient's lips. They should be moist with normal color. You should not see lumps, ulcers, cracking, or scaliness. Ask the patient to close his mouth. The lips should close symmetrically. If you see any suspicious lesions, palpate the lips, which should feel soft and smooth. Be sure to document abnormal findings. Then assess the oral mucosa, using a tongue blade and light source. Normally, the mucosa is pink, smooth, and moist, with no lesions or nodules. Remember that in a dark-skinned patient, you'll commonly see increased mucosal pigmentation. Next, assess the patient's teeth and gums. Normally, adults have 32 evenly shaped ivory-colored teeth that are firmly embedded in the gums. Now inspect the rest of the oral cavity. The hard palate should appear bony and whitish. The soft palate should look